The position looks correct. If you agree, we can inflate at that stage.
Yeah, and I don't know what your thought is. I usually do an intermediate sort of pressure first, just to, bearing in mind we've changed the compliance of the vessel, we can always inflate to a higher. I'm at 16 at the moment, it's nicely up.
Okay. Deflation. I will remove the balloon. First I push on it to try to disengage it from the stent, and maybe we can measure, and why not inflate at that stage to prepare a little bit more the...
Nice.
So the first stent was 24 millimeter in length.
24.
How do you evaluate the length of the proximal stent now we need?
With 24 millimeters, normally we should...
It looks nice, huh?
Cover just... Cover the proximal portion of the...
And concerning the size, we take a 275 or a larger stent, 30?
And the proximal portion of the LED seems quite large, in fact. Maybe 275 can be a little bit too small.
A 3, I would have thought, would be very reasonable.
So 3024 resolute stent.
Yes.
Mike.
Excuse me? Yeah, I show you with the laser point. The guiding was a little bit inside of deep sitting in the left main. And this, of course, we have, when you are working, immediately when you see this, you have to remove the guiding. You're right.
Yeah, Jean,
yes.
the most common question, which stent for which lesion? I mean, I think this is the Endover Resolute. It's not Endover?
This was a Resolute 24. Yeah.
Do you have any evidence of using Endover Resolute in calcified lesions, or because we know from the past that the Cypher stent with high radial force is the most appropriate stent for the calcified lesions. Correct me if it's wrong, because we don't have data for the Endover for calcified.
I think the most important is the preparation of the plaque.
Okay.
And then the post-dilatation. And the stent is just used and implanted, you will see here in that 14, 16 atmosphere, not very high pressure. And then you will see it will come back with a 3 millimeter balloon, 22, 24 atmosphere, in order to be sure that we will implant it.
This makes me another question.
Really the type of the stent.
If the stent cannot pass after dilatation, the rotaplators of the rota and then ballooning, and sometimes you cannot pass the stents, are you going to do rota again or balloon again, or you put body wire, or this is the problem, the stent?
No, in this case, for example, the balloon was used after the rotablation was 2.5 millimeter. If you could not pass the stent through the lesion, what you can do is to take a 275 balloon or 30 balloon, take high pressure, and then you place a stent later. Yeah. It's what we are doing. I think we can move to the... so concerning the question of Galal, it's the 275-24 Resolute.
Sorry. And often it just hits, well done,
I think that
the nose of the distal
yes,
stent.
The nose of the stent hit most likely the implanted stent.
Test. We have to push a little bit, I think.
That's close. If we took a digital acquired image, we may well be able to see that distal stent a bit better.
Okay. A stent boost, maybe a stent boost can be useful.
Good idea.
So you see that the problem, the difficulty
here
is
we can see that
really
it is close, but maybe that
the junction
there
between
is
the two
one
stents
thread
without
missing,
a measure
because
overlap.
we can see that the distal marker is just
we use
in
a stent
the
boost to do
proximal
that.
portion of the stent, but the stent itself is not overlapping.
Yep.
So we have to push a little bit.
But the difficulty here is that here you have the stretch of the distal stent, and we have also the calcification. So the stent boost in very calcified lesion, it's very difficult to interpret it.
But we have to withdraw 1 millimeter for the proximal portion of the stent, the lesion.
I think
Here,
close, yeah.
here it can be very close.
One more stent boost?
Yeah, let's repeat the stent boost to be sure. Because I think it's okay.
This is the stent.
Because the proximal portion of the stent is not fully deployed, as we can see. It's a little bit conic, and it seems that the threads are overlapping, that the distal marker of the stent is inside the previous stent. And the overlap will be very, very short, but will be present normally. So maybe we can inflate, Martin?
Okay.
Okay. 18 atmosphere. Deflation. And what we try to do is to have a good expansion of the overlap. So the profile of the balloon is not very, very
there you go.
good, but we're getting.
Now we place the balloon between the two stents in order to inflate in the junction zone.
Okay.
Looks pretty good.
The result looks acceptable, but we have to be sure that just at the zone of the overlap, there is no waste of the stent. So maybe we can go with a high pressure balloon, inflate at that point. What is your opinion?
Yeah, if I look at the angio, there seems to be a little bump there. So I agree with an extra dilatation. With a short balloon, doesn't need to be that long. I think I would go for a 3 or a 3.5 even. I do not know what your thoughts are about the size.
Maybe a 3.0 short balloon should fit?
Yeah, I think, I only went to 16, and we can take a 3 up to 22 or 24, and hopefully that will suffice, I think.
And certainly we also have to inflate inside the first stent.
Distally.
Maybe not distally, maybe not at the same pressure, but we have to make sure that the expansion of the stent at that...
Just before the septal.
Exactly.
Yeah.
Okay, so we have selected a 3.0 by 12 quantum balloon, non-compliant.
Yeah,
but
good.
We are here now. Maybe at 10. Yeah. Okay. One inflation here. We're going to make a step dilatation through the whole stent to be sure that we have correct. You can go to 16. Okay. Inflation. We are getting close to the overlap, which is here.
Yeah. That's where we really would like it up.
Here we can go at very high atmosphere pressures. Okay, 22.
And this is sort of an important part of this procedure, especially as, if there is going to be any talk of having slightly less dual antiplatelet duration, you really want the
result is better.
Yeah.
Even the distal stent, there is still something, but we don't want to go with too high pressures because there is a clear risk of rupture.
Yeah.
If the calcified plaque is eccentric, we can damage the contralateral, the opposite wall.
Is it worth just taking one or two other views just
sure.
to be sure, and then I think that's nice.
It's nice. Even the distality of the vessel looks good. There is no perforation because we have manipulated several wires, so we have to check for this also. Maybe we can withdraw everything, take a final shot.
Nice. Very good.
It's very good. Okay, I think it's what do you think, Peter? It's a very good result when you see the baseline angiography at the beginning, this long calcified lesion, later be tortuous, and with this technique we obtained this result. So we can summarize this patient as the following. I think that what we have learned in this case is first the need for preparation of the plaque before stenting using rotablation, atherectomy. Second, we have really a good demonstration of the manipulation of the wires, starting with the conventional wire, then exchanging the wire for rotablation wire, then come back after the balloon dilatation to the conventional wire to place the stent. The third point, I think, which is important, is the time they take for placing the stent, particularly the proximal stent with accuracy, and the second to finalize the post dilatation in order to optimize the stent deployment. Any other comment, Peter?
No, the only thing is the precision of aligning the two stents coaxially. You used various techniques, angiography, but also the stent boost technique. There's little that I can add. And of course the question of antiplatelet and comadins, but that is a discussion that we will have to have after the procedure.
Okay, thank you very much, Didier and Martin, for...
Okay, so any comment concerning
regarding
the
long-term antiplatelets?
And the problem of antiplatelet?
Yeah, you know, Endeavour, I think in the beginning of Endeavour Resolute, they said that it can be used only for 3 months as the Plavix, because it's non-polymer, there's no least stent thrombosis in Endeavour. Maybe this is the choice for this elderly patient. Sometimes can be used in acute infarction. But in this patient, do you advise that to use the triple therapy for a longer period with INR less than 2 for this patient, or you, according to the active A trial, you can use only aspirin, Plavix, and stop or Coumadin?
No, what we say to the patient discharged with a report, and the report was printed as follows. They said Coumadin and aspirin for life and Plavix for 1 year.
1 year or 3 months?
From 1 year.
So you
because this one was it's a Resolute, it's not the Endeavour, the first generation.
Okay.
So it's true that with Endeavour, the first generation, because of the PC coating, etc., and the healing was not so delayed, and there was we could stop the Plavix 3 months post procedure. Here, this is totally different because the polymer is different, the late loss is different, and so we have to consider this new generation of Endeavour stent as the other generation. So what will be interesting for the future, maybe with the bioabsorbable polymer stent, or for the future, next future, very, very soon, the polymer-free DES. Maybe this will change this policy for dual antiplatelet therapy, but we don't know. We have to prove this. We have not the data, etc., etc. So it should take a long time.